Good afternoon, and thank you everybody for joining us today for the webinar. My name is Dr. Sean Gamble, and I'll be moderating the webinar today for you. You'll learn more about myself and the speakers shortly, but first I wanted to introduce everyone to the concept of NRFit and briefly explain why I feel it's so important for us to consider implementing this new change at our facilities. NRFit, for those of you who do not know already, is a new type of medical small bore connector that was defined by the ISO 80369-6 and was designed to reduce the risk of misconnections of neuroaxial products in the field of regional anesthesia. Misconnections, as you can imagine, are quite dangerous in the medical field and can sometimes lead to even fatal outcomes. Because facilities and various departments all use the same Luer connectors, you can see how this can become dangerous. And administering the wrong medication into the wrong tubing or connection has happened in the past, and it's still happening today. NRFit is meant to create its own connector for neuroaxial and regional anesthesia connections. So what is NRFit? Well, NRFit are connectors that are actually 20% smaller and 3 millimeters longer than a standard Luer-Lock. Therefore, it is 100% impossible to connect the inappropriate syringe to the inappropriate hub. And so this prevents, is what it sounds like, the inability to accidentally connect IV tubing, for example, to a neuroaxial connector if the two are not compatible. There is also a yellow color coding system associated with NRFit, so it provides for easy recognition by staff, especially on the fly, or with busy schedules, and this bright yellow coloration helps prevent misidentification of medications or syringes that would otherwise be connected to the wrong system. Now, what is the ISO? It's the International Organization for Standardization, and it introduced this ruling of 80369 back in 2016 to standardize connector use for common procedures and to move away from the Luer connector as a standard interface for different devices to reduce the risk of misconnection resulting in serious injury or death. And so as you can see, they've basically looked at making it mandatory, or at least the best recommendation from a patient safety standpoint, to change the connection size between all of these different systems and areas to prevent accidental misconnection. For example, you may have heard about the enteral and gastric application NFit. NFit was designed and mandated to prevent the misconnection of gastric feeds, for example, to an intravenous connection, which has happened. Now, advocates in California got legislation passed in 2008 that would have mandated that feeding tubes no longer be compatible with tubes that go into the skin or veins by 2011. Ultimately, they were also successful to legislate and to mandate in 2017 when they got the Bill 444 passed, which also eliminated the use of a universal connector for epidurals and neuroaxial medication delivery. And that's what we're here to talk about today, which is the NRFit system. So now that you've learned a little bit more about the importance of NRFit and what the NRFit connector is, what happens next? Well, stay tuned to the webinar as we're about to review and meet a couple of gentlemen from across the pond that have actually converted their entire hospitalization systems. And they're here to tell us a little bit about how they did that, some of the pitfalls that they discovered, and give us some tips about how to proceed in our own systems here in the United States. And how can PAJUNK help us do this? Well, we're currently in the state of exploring this conversion ourselves here at my hospital facility, and PAJUNK's been, very helpful and supportive in doing that. They help us set up meetings with the appropriate individuals that need to be present to discuss the appropriate conversion, and they're also currently helping us develop cross-reference lists, which identifies all of the products that you may or may not think of that need to be available in an NRFit connector in order for a seamless transition. They've also got training tools that we're going to be taking advantage of, and tons of support and resources that will be available to you in your facilities should you decide, like us, to make the switch.
So with that said, I'd like to introduce our speakers today who are graciously joining us from across the Atlantic Ocean. Our first presenter is Dr. Robert Zanner. Dr. Zanner studied medicine at the Technical University of Munich Medical School in Germany. As part of his training, Dr. Zanner actually came to the United States, completing portions of his medical education at the University of California at Los Angeles, and then at the Mayo Clinic here in Scottsdale. Following his graduation, he completed training in anesthesiology, intensive care, and emergency medicine with the Department of Anesthesia and Intensive Care at the Technical University of Munich. Currently, Dr. Zanner practices at the Technical University of Munich, and his clinical interests include patient safety, regional anesthesia, and simulation for education in anesthesia. He has a research focus on EEG-based anesthesia monitoring mechanisms and mechanisms of anesthetic-induced loss of consciousness. Thank you very much for joining us today, Dr. Zanner. Our second speaker this afternoon is Dr. Carl Hillermann. Dr. Hillermann is a consultant anesthesiologist at the University Hospitals Coventry and Warwickshire NHS Trust in the UK and has been with them since 2004. Originally, he was born in South Africa and completed undergraduate studies at the University of Pretoria. Following his initial training in anesthesia in South Africa, he moved to the UK, where he completed his training, and he is the current clinical lead for acute pain, regional anesthesia, and simulation at his facility. His special interests in research include both regional anesthesia and pain medicine, with a focus on the use of regional anesthesia in trauma, in particular for pain management chest trauma. Dr. Hillermann is also the primary examiner at the Royal College of Anaesthetists and chairman of the MCQ exam. Thank you for joining us as well today, Dr. Hillermann. And without further ado, Dr. Zanner, I'd like to turn the floor over to you to begin today's webinar.
Okay, thanks for the introduction, Dr. Gamble. Hello and greetings to everyone from Germany. The sun has already set here, but I hope you enjoy a beautiful afternoon in the States. Now, before I go into detail about our transition process, let me give you some relevant background information about our hospital, about our department, about our infrastructure. Our hospital is actually really old. It has been around for quite some time. It was founded in 1834 as an institution for the poor and the ill. And in the late 1960s, when the numbers of med students in Munich were growing, the government decided to found a second medical faculty, and our hospital became University Hospital and was growing ever since. Today, we have around 1,200 beds. You can find all surgical and medical specialties with the exemption of cardiac surgery, which is located at the Technical University Heart Center nearby. Our department is the largest department of our university hospital. We have more than 180 anesthetists and provide more than 40,000 anesthetic procedures per year. We have a focus on peripheral regional anesthesia in all kinds of trauma and orthopedic surgery, as well as in vascular surgery. And as our hospital has a cancer focus, we also have a lot of big cancer operations to all the specialties. And so we also focus on the central regional anesthesia and, of course, for labor. We provide a post-op pain service 24/7 for our patients. Now, this is a little map of our campus, which shows you also one of our big difficulties in planning and organizing things. Our hospital complex consists of a lot of different buildings which have been interconnected over the years. And if you want to change something, you just cannot tear down the old buildings because most of them are preserved as a monument. And so you really have a hard time. In former years, usually all the specialties, they all had their own operation theaters, their own post-operative recovery units, their own infrastructure. And during the last 20 years, there was an enormous effort undertaken to centralize all the operation of the surgical business. So today, we have three main operation centers. And the GENOP department just close by to one of the centers. When it comes to our supply infrastructure, we have one main storage site where all the consumables are stored in large quantities. From there, all the anesthesia and OR related things go to two other smaller sites that are just located at the OR centers. And from there, we get our replacements to the OR. Now, this is just a storage cabinet that we have in our preparation rooms. All the articles stored there have their own sign with a barcode, and 3 to 4 times a day we have service assistants. They go through all these cupboards and refill all the things that have been taken out, and scan the barcode. So there's an automatic order to the main storage site to refill the smaller storage sites. Now let's go to the transition process. So the first time we heard about NRFit was in the last quarter of 2018, when our PAJUNK sales representative came to us and told us that all the regional portfolio of PAJUNK was now available also with the new NRFit connectors. So we didn't know much about NRFit and got a little bit into detail. What is the background? And we thought, well, it should be a good idea to make a transition to NRFit, because it's a huge opportunity to increase patient safety. And since everything was put down in an EU and ISO directive, probably it will become mandatory at some point. And we wanted to avoid a run when there would be a deadline when you have to transfer. So we wanted to be one of the first institutions to do this and have our time to plan properly. So at that time, there was not much experience with NRFit in Germany. There were a few small hospitals that had converted, but nothing of our size. And we had the luck that we got a little bit input from a large hospital in Austria. So we started planning with a little bit of information just after the Christmas holidays in 2019. And we started with setting up a project group. The project group consisted of members of the purchase department, also of the anesthesia nursing staff and anesthetists. We planned to do the conversion within about 4 to 6 months. And then we looked for a good time point in this time scale where we could do the transition. But I will come back to that later. So the first step was to identify all the relevant products that we had in our hospital. So we did a database research, and we found, of course, the regional anesthesia products. On the one hand, our sets for peripheral and central regional anesthesia. Just a little explanation. We use sterile base sets in our hospital, which has they have all the necessary materials like sterile drapes, sterile swabs, syringes, everything for local anesthesia, sterile ultrasound cover, and then on top we put the next set according to what we want to do, like a peridurals catheter, epidural catheter, or central venous line, regional catheter, whatever. Then next we had the material for the PCA equipment, and of course consumables like syringes, caps, and so on. We also looked in other departments for example neurology, because they do lumbar punctures and need materials. Oncology I put in brackets because at the planning phase we just forgot about them. We contacted them that later. And we also contacted the neurosurgeons because they had materials for the external ventricular drainage, which could be converted to NRFit. So the next step was to check if we have NRFit alternatives available for all these products. And for the regional anesthesia sets, which we already had from PAJUNK before, this was no problem. This was a matter of a couple of emails. They knew exactly how many sets we used per year, and so this was no problem. The patient-controlled anesthesia equipment came from another supplier, but they also said time frame 4 to 6 months is enough, so they could provide us with enough tubings and cassettes and stuff. And the third manufacturer of our consumables was surprised because they never thought that anyone would convert to NRFit at that time. And they said that they need at least half a year to get the large quantities that we needed. So we didn't want to postpone our transition. So in the meantime, we got our consumables from PAJUNK. Our neurologists, they didn't want to transfer to NRFit because they don't put anything in, they just drain liquor, so there is no risk of mixing something up. And the materials for our neurosurgeons for external ventricular drainage was not available at that time as NRFit. Then we got test samples for all of these, for all the available products, and tested them, and we couldn't find any difference in using them with the Luer equipment. So then we started a big information campaign that everybody who was involved in the transition was also informed of what we're going to do, what was the background, and all the warehouse personnel was informed by our purchasing department. Our doctors and nursing staff, they all had lectures about NRFit and the background, and we were also provided with posters with relevant information from PAJUNK, which we could put up at an intensive care unit or in our ORs. And we also had the opportunity to use an online training from PAJUNK, which we could tailor to our needs, and everybody could use this online training and get a certificate at the end. And of course, we informed the labor room staff, especially the midwife, because usually they provide us with the materials when we go there. Okay, when it comes to realization, I told you that we were looking for a perfect time point in this 4 to 6 month time frame, and we found the Easter holidays to be probably the most suitable time point, because in Germany we have four days off in a row. There's no regular OR schedule. And so we have a long time where we can decrease the use of our Luer materials and start with the new NRFit connectors. So our plan was to use the Luer sets until Thursday and start on Friday, with NRFit. So all the catheters that were placed until Friday with the Luer systems, or at least most of them, should be already removed by Tuesday. So in the storage, in our large storage warehouse, we had both Luer and NRFit available for several times. We also already got it earlier before the transition point, so that everything was in place. And we also had an agreement with our manufacturers that they would take back all the Luer equipment that we didn't use. In the storage locations just at the OR centers, we stored until Thursday the regular Luer equipment, and then transitioned in the night to NRFit. We kept just a few Luer sets just in case. And in the operation rooms, we used the Luer equipment until the end of Thursday, and on Friday we started just using NRFit exclusively. So our experience during the transition on the weekend or on the Easter holidays, we didn't have any major problems. We had our PAJUNK sales rep on call, so if there would be any problems, that we had a backup and get stuff if we needed something, but there were no major problems. During the first weeks, we found out that more information was needed. We didn't reach all our staff. Some of them were on holiday or rotated somewhere else. So we did some more information. There was one program with our infusion pumps because they are capable of using all kinds of different syringes, but they were programmed for whatever reason to just accept one kind of Luer syringe. So we had to reprogram them, which took a little time for a few hundred of pumps. And the supply of our PCA pump tubing was not sufficient. So we had a short period of a few days where we had to use the infusion pumps instead. Then after a while, everything went fine. But after a few months, we found out that we forgot something. And that was when we had to perform our first blood patch. Because we didn't have any NRFit equipment to draw blood from the vein and inject it directly back there. And of course, it's no good idea to use Luer to draw blood and put in another syringe and then inject the blood. But we found a good solution with a butterfly and NRFit connector, which we are now using. So in summary, I can tell you that proper planning reduces the stress level. Input from others is helpful if there is any input that you can get. Most important is that you know your local circumstances. Every hospital has a different infrastructure and you just have to know everything about that. And you have always to have a plan B if there's something you forgot and something that might go wrong, and then everything should go well. So at the end, I would like to thank our whole team, Svetlana Springer and Sandra Baumann from our purchase department, Steve Brachwitz from the nursing staff, and Thomas Wilhelm, our PAJUNK sales rep, who really did a great job in supporting us there. If you have any questions that we cannot get to at the end of the session, don't hesitate to contact me, send me an email, send me a note, and I will try to get back to you and answer your question. Now I'm the end of my talk, and I would like to hand over the virtual microphone to Dr. Hillermann.
Thank you, Dr. Zanner. I'm just sharing my screen. There we go. Yes, and I welcome everybody. I think it's good morning to you. It's nearly dark where I am too. After a day at work, it's good to be speaking to you across the Atlantic. I'm based, as Sean said, in Coventry, which is in the Midlands, about 1.5 hours north of London. And that's the institution I work in. It's from a capacity size, it's very similar to the institution that Dr. Zanner works in. We've got about 1,200 beds. The good thing is it's all on one campus. There are 23 operating theatres in one suite, and then we've got a day case unit with another 5 theatres. And and we are a local major trauma centre. Coventry, just some background, Coventry is actually the city of culture for the UK. This year was supposed to be last, but because of pandemic it was referred, and there's just a collage of pictures of the city that I work in. So NRFit in our institution. So Dr. Zanner has gone through sort of the process of how it goes. I'll just give a short overview of how it went in our hospital. And I'll start off with what our drivers for change were. And we had a NPSA alert, which is a National Patient Safety Alert, in 2017, recommending that we all transition to NRFit from Luer-Lock connectors. This has been a long time in the running, and because of some problems in hematology with intrathecal injections, some never events, and some catastrophic never events which occurred there, and also in anesthesia. So the history is there had been a previous attempt to move from Luer-Lock, sort of 10, 15 years prior to this, but the success of that wasn't very good, and it was stalled until NRFit came along. So in the way in the UK it works is the NHS, most of the hospitals are NHS hospitals, and a lot of these things are controlled centrally. So we had to, in the next few years, change to NRFit. We also have a surveillance of never events, and just after this patient safety alert came out, there was a wrong route drug administration. It was a local anesthetic infusion device was connected to an IV giving set. So, and that led to a series of things, and one of the things was that we had to, that we decided to change to NRFit. Now, unlike Dr. Zanner, our strategy was slightly different, and it was because we were one of the first to take up NRFit. We couldn't do it all in one, so it was more a once the product becomes available, we will introduce it. So in 2018, we were able to convert the first, and there was the spinal needles, and so that was the first big change that we made. And what surprised me was how many areas actually use spinal needles, from surgery, neurosurgery, medicine, radiology, pediatrics, all of them use spinal needles. And as a trust, as a hospital administration, we decided that we would change all of the spinal needles, because procurement is done centrally to one central store. And if we would have different spinal needles, that would just cause more problems. So we embarked on this change in all areas. And one of the big barriers for change was individual needle preferences, especially from some of the surgical groups. Neurosurgery springs to mind, where each surgeon has their special needle, and it took some time and some persuasion to convince them that the needle itself hadn't changed, it was just the hub that had changed. And so, but with some time, similar to, we also had some online material which we used for education purposes. We had roadshows in all the areas to make sure that everybody was aware of what was happening, and a little coalition of helpers from procurement, and brought some individuals from the different areas to sort of push the change in their areas. And then we had some great help from the PAJUNK UK team, who visited us regularly and visited all the areas to help with the conversion. So the implementation process was also done on a single day. So we introduced, so Luer-Lock, this is now for spinals, stopped on the Sunday, and on the Monday morning, we went over to the NRFit. One of the big things that helped us, because storage in our theatres is problematic, there was some concern about all the new types of syringes and so on, and where would we put them. And one of the things that we came up with are these regional anesthesia trolleys, where you can see on the photo on the right hand side, there's 4 drawers with needles in the first 2 drawers, and then the syringes, and then we've got the packs for sterile procedures in the bottom drawer. And this was a great help, because we did manage to have all the equipment for regional anesthesia in one place, in one trolley. In the initial implementation period, we had daily implementation debriefs after the day to make sure everything is is working well, and there was great cooperation from our medical stores department. And again, during the transition program on that Monday, the PAJUNK team was there. So here's a sort of a time frame of our transition that we had. So as you're aware, at the beginning of it, I said it came out in November 2017, and we had our critical incident or never event 6 months later. And then we had a root cause analysis, and the recommendation was to convert to NRFit. And from June 2018, 3 months later, at the beginning of October, we implemented the spinal needle. And then there was we wanted to do spinal needles and single-shot regional needles at once, but there was a problem with supply, so we let that go to the first week in January 2019, when we did the single-shot spinal needles. Subsequent to that, you'll see there's a big lag, about 18 months, where we had a issue and we couldn't convert to the epidural and continuous catheters, continuous nerve catheters. This was, the needles and the kit was available. However, our supplier of the infusion devices, that connection from the infusion device to the catheter was problematic, and the company hadn't produced the connection, so we could not implement epidural needles until October 2020. We tried on 3 occasions, and every time it was ready, but then it didn't materialize, the infusion sort of connections. Then we had another critical incident, this time in labor ward, another wrong route drug administration in July 2020. And with that, we were able to put some pressure on the company, and they managed to get us the infusion connectors. In October last year, we implemented the continuous epidural with the NRFit. And subsequently, in this year, we managed to convert the final, which was the continuous nerve catheters, to NRFit. So as you can see, it wasn't that smooth a process, and it took time, and it was particularly took time because we couldn't get those connectors. Otherwise, the plan originally was also to do it all in a short space of time. So reflecting back on you know, how we did it, I think what could have been better is the time frame. It took time to do it, and sort of we had to be, it took another critical event or to sort of push the company to get the infusion device out. So so that's in the planning, and the giving set NRFit compatibility is a problem, and that's just one thing. When you change over, you have to be aware of this and make sure that they are available. What went well, I think it was that there have been no further serious untoward incidents with this, and there was no untoward incidents during the process of changeover. I think the having the separate trolleys, making sure that there's a, you know, that the syringes and everything are kept together, has improved that, and to make sure that there's no issues like, you know, doing the spinal and not having the correct syringe there. It's also been an advertisement for regional anesthesia in a way. We've got those trolleys now, everybody is aware of it. Through this whole hospital-wide campaign, more and more people have become aware of regional anesthesia. So as a sort of the side effect of the whole process, regional anesthesia is really come to the fore, and we've actually increased the amount of regional anesthesia that we are doing. And the other thing that I can't stress is to get industry support. They're great help to make sure that, and having contact with them is very good, because you can ensure that the supply lines are all open. And I'd like to thank them again, PAJUNK UK, for helping us through this. That's the end of my talk. If some questions are not, if we can't answer all questions, you can send questions to me via Twitter or email. And then before I hand over to Sean, I just have to, you can also get a poster from PAJUNK UK, write the details down, get in touch, and they'll send you one of these posters. Okay, that's it, Sean.
Thank you very much, Dr. Hillermann, Dr. Zanner. Great information, and hopefully we'll have some great conversation and questions. We're going to open that up in just a moment. I'd also like to just take a minute and thank ASRA as well as PAJUNK for coming together and putting this webinar together for us. Like you, we're at the initial phase at looking at doing this system and this conversion, and so I have a lot of questions, and hopefully there's some good questions coming through. In order to answer those questions, go ahead and place them into the Q&A box, and we'll sort through them. And any questions that don't get answered, we can have them summarized later on, or you can always connect with our speakers directly. Guys, just off the top of my head, I wanted to ask you both, having gone through the process and being at the initial phases now, where we're currently looking at auditing sort of all of the materials and all of the departments that would be involved, it sounds like the two of you came at this from a slightly different approach. At your facilities, who was the champion for you guys that sort of kept everybody together and brought all of the appropriate parties together during this process? Was it you individuals, or was it other individuals in your facilities?
If I may start, I think in our project group, especially the members of the purchase department had the biggest part, because they had all the overview over the materials. They did database searches and get us all the reference numbers and stuff. So it was really easy to look after NRFit replacements. And they also had the contact with the industry, and they got input from us from the clinical point of view. And so it was, they were the center of the transition process, I guess.
Yeah, it was very similar with us. We, because it was an anesthesia-related never event that occurred, it sort of fell on the anesthetic department, and being the lead for regional anesthesia, it sort of fell on me to start the process off. But it's the same as with Dr. Zanner. In the end, it's a big team effort, and procurement department, or in our hospital, they know exactly where the equipment goes and so on. So they knew which areas use it, and the quantities of what is being used. And it was a quick collaboration attempt between everybody involved, really, to get the initial thing off the ground.
Okay, thank you. A couple of questions that are coming in. One of them is from Logan Pearson, who's actually one of our pharmacists here. Logan, I'm going to go ahead and read your question word for word. Hello, from a pharmacy perspective, with epidural injection preparation, was there significant issues with having a separate stock for compounding these epidural injections, such as separate syringes, needles, adapters for compounding from multiple vials in the clean room? In other words, in our facility, everything is prepared in the pharmacy for us. The CAD pumps are filled in a sterile hood. So I think that that's where they're asking sort of logistically how that worked for you all.
So if I may start again. We have a different approach. We do not get our medications pre-filled from the pharmacy. So when we place an epidural catheter, the physician who does the procedure also prepares the mix when he is completely sterile, just in the OR preparation room. So therefore, we don't have any issue with that.
Do you run your, sorry, second question, do you run then a syringe infusion on like an Alaris pump or some other model of pump that you fill yourself, you verify the concentration? Do you have somebody else, confirm the concentration before you do all that?
We do it all ourselves, all by ourselves.
So one person verifying, one person mixing, one person, okay.
Yeah, so with us, it's slightly different. Pharmacy doesn't fill the local anesthetic device cartridges for the CAD Solus pump. It comes in, it's sourced from outside. So we buy a finished product, which we then slot into the pump. So they didn't have to make it up in pharmacy. I know, however, that they do make up some of the chemotherapy drugs for hematology. So they and they also have their own store and supply of needles and syringes. As far as I know, it's not a big problem. The needles or the syringes had to specially be tested for that, and they got their CE mark and so on for that. And it doesn't seem to be a problem that pharmacy now that they ever run out of these. They just know that they're there. I think even initially there wasn't a problem with stock at all. We used to make up our own infusion devices for the continuous nerve catheters, but that's also been outsourced. So the finished product comes to us and we just then need to connect it. The one downside is that they're all the same concentration, so we can't increase the concentration or decrease the concentration, and it's all just levobupivacaine that we get. So there is no problem in sourcing those either.
Gotcha. And I know in speaking with our own local rep, we understand that they were able to acquire all of the appropriate sort of syringe sizes, as well as the CAD and conversion to the NRFit catheter. Do either of you use CAD pumps?
Yeah.
You do. So the CAD pump has an NRFit connector that connects to NRFit tubing that connects to the NRFit. Gotcha. Thank you. Another question that came in from Jen Berblick. What is the biggest obstacle? I know you guys have touched on several things. What is the biggest obstacle that you faced throughout this process?
Well, I guess since we didn't have real problems in getting all the materials, it is just with every other conversion, when you introduce something new, people are skeptic in the beginning. Why do we have to change? We had some good old stuff which was running over years, and in our hospital we didn't have or encounter any never events like Dr. Hillermann did, and so there's always skepticism. So it takes some time to get all the people convinced that the conversion is necessary, and especially it is something good. So this was for us, as with all changes in material, the biggest obstacle.
Thank you.
Yeah, I think from our side, we had the same issue of change, even though we had never events. Individuals don't like change at all, and it does take a lot of convincing. And if you had secret stashes of the Luer-Lock needles, because they are, they're the only needles that work, but we managed to convince everybody, and we had continuous audits to try and find out if there's any others, and the uptake, was good, and now the whole trust or hospitals is using it. For us, the biggest obstacle was that we had the issue with the connectors, and we couldn't implement it. And I think that was part of the problem of being an early converter to NRFit, that we had the needle supply, we had the catheters, everything was there, but we didn't have the connectors. And there was, you know, there was some where we could have like a Luer to non-Luer connector. We could have put that in, but we decided from a patient safety aspect that we wouldn't do that, because that just brings another layer of potential issue into the equation. So we just waited till they became available.
Gotcha. To add on to that, was it your facilities that worked with your suppliers, and did PAJUNK, I guess, supported the process of identifying where hubs and such needed to be transitioned? How did that process sort of work out?
Okay, I can start. So, I mean, it was, I mean, we went to PAJUNK initially because of the NEVA event to start the process off, and so that was that, and then they provided the materials, all the different types of needles. They came with loads of briefcases to show all the parties the needles they have, etc., etc. And it was mainly trying to reassure that the change, what the change involves. But it was mainly the committee that were formed to deal with this, that had to go to the individual specialities to help push the process forward.
Gotcha. Thank you.
Okay. With us, it was the other way around. So PAJUNK came to us because we already had our Luer packs for regional anesthesia from them. And they just told us, as I said in my talk, about the availability of NRFit materials. And so we got into this whole process.
Gotcha. Thank you. Another question that just came in through, it looks like the chat box. Gentlemen, how did you address off-label use of anesthesia spinal needles and the shift to NRFit connectors? Did you experience pushback?
I think I've probably answered. We did experience pushback from, especially, it was mainly radiology. They use it for injecting into joints, etc., because they felt that's what they just used. They liked the needle. And also from neurosurgery, when they introduced, and neurology for their monitoring of central CSF pressures with manometers. So that was probably where we had the biggest pushback initially, was there, because they felt that it wasn't a necessary change because they don't inject anything. But we had the support of our institution that it wasn't a good idea to have two different types of spinal needles at the hospital, and that would potentially lead to more patient safety problems.
Yeah, well, I don't really know about off-label use of other departments in our hospital, so that they would use spinal needles for anything they shouldn't do it. As I said, our neurologists still don't want to go or change to NRFit because they don't inject into the spinal room, so they still use the Luer ones. But I think at latest, when there will be a deadline to convert, they will convert too.
Yeah, actually, I'm glad that you guys both brought that up, because you know, I was originally wondering, for, you know, other than the obvious, the never events, what was the motivating factor? And, you know, here in the United States, at least, there hasn't been a you know, none of the hospitals, the big hospitals, are really in this under a centralized, organized body from a mandatory standpoint. In California, actually, in 2017, they did enact some laws that are directed towards transitioning both neuroaxial access as well as enteral access to a different connector from Luer-Lock. And so, you know, obviously there's that driving force. For me, in my facility, we've had some very close calls, connections of IV PCA to epidural or vice versa. And those I've seen a few of those in the short time that I've been here. Are you folks aware of the actual incidents of these events that spurred the lawmakers to bring these changes about, like in your countries or in California? For example, we in America, we have the Closed Claims Project since 1984, which tracks these anesthesia-related events and outcomes. And so we have an idea of the incidents, but I wondered if you all knew how often these types of misconnections are occurring and what frequency and severity.
We have the National Patient Safety Agency, NPSA, so they look at all these. There's also because it's our organizations work slightly different because they're central control, so we have to report these never events or these misconnections. So it's driven from that. I can't off the top of my head say what the numbers. I just know from the numbers in our institution over the last 4 years how many we've had, and they were near misses rather than it was connected but only connected for 2 minutes or something before it. But for us that is a never event because of the potential harm. But on a national level, I'm not quite sure. We have the same with in ITU with the enteral feeding. That's all a different connector now. So so enteral and peripheral nerve or epidurals are all now different connectors. But it's from a central. There's no timeline as to when all the hospitals have to have been converted. I know that I spoke to some, in regional anesthesia, it's probably more than 50% of the hospitals have now converted their regional anesthesia to NRFit.
Yeah, I don't know of any organization on a national level in Germany too, which is evaluating all the incidents. Of course, we have a hospital-wide system to get information all about that. But there have been so many never events which were in the press, where a patient died because of misconnections, and I guess this is force enough just to get out this European Union directive or ISO, which regulates all these different connectors, because there have been several never events, and I think this is the driving force.
Yeah, no, I think that like you, Dr. Zanner, I'd like to be ahead of the curve on this situation. I think it's an inevitable thing that's coming. We're seeing it in California already with their law being passed, and they do have I think with COVID, things didn't get as enforced as they will have been or will be, but we'd like to certainly be ahead of the curve. And for me, just seeing the close calls that we did, and to think of what the outcome could have been was scary enough for us to obviously get invested. One question that you had brought up that I wanted to ask about, and how you overcame the blood patch issue. Can you go into that? Because you're right, it would be quite cumbersome to have specific tubing for an IV access to then transfer that immediately into the epidural space. And then you've got sub nuances when you deal with folks that I've done a very interesting blood patch on a Jehovah's Witness patient that the only way they would allow us to do it was direct connection from the arterial line to the epidural space. We couldn't even put it in a syringe, so that's a whole nother subset of problems there. But how did you overcome that issue?
Well, as I said in my talk, we experienced this event just a couple of months after we transitioned, and the first thing we did was we contacted PAJUNK, and they sent us. They have a blood patch kit packs, which consists of syringes with of Luer syringes with an NRFit connector, which is put on top. And but after some searching on the internet, we found this little butterfly which already had the NRFit connector at the end. So there's nothing with an adapter you have to screw on or something like that. And you really can draw the blood into an NRFit syringe. And this is, I guess, the most easy way to overcome this problem.
Okay.
Yeah, we've got a pack which includes a butterfly, a syringe, all NRFit. So which comes, the UK team of PAJUNK have put together to us. So we just open a blood patch kit and it's all there for us. Now with the Jehovah's Witness, we've also had an issue previously. I'm not quite sure how we are going to overcome that yet, because you'll need a connector of some sorts between there or something. It makes it a lot more tricky, but we haven't.
I think moving forward, I'd try neostigmine.
I think what you alluded to earlier about being ahead of the curve, I think in retrospect, being sort of your arm being twisted to do it is not the best. It's never nice to be told you have to do something. It's always better to be told. But all I can say is, having converted, there hasn't been a problem with the equipment from an anesthetic perspective. You know, there's a lot of folks that are concerned that it doesn't feel the same, that all of that. There's no problem with that. It all feels exactly the same. If you use an NRFit or a non-NRFit, it's exactly the same. But I think it's the safety profile which increases in magnitude is the main driver that everybody should use and think about changing.
I think it's important that you touched on that, because it was one of some concerns that some of the physicians had, that well, you know, I'm used to this needle, I'm used to this epidural kit. What's been really nice is the customization. We have several kits that were built for us that include, you know, different prep sticks and different dressings and different things, and everybody gets into their niche, but it's the ability to swap things out pretty seamlessly for me, that and the safety aspect that it offers to prevent these catastrophic events from happening, that makes it so attractive. And like you said, I think it's important to be ahead of the curve rather than on the back end, where you're being forced to meet deadlines, etc. And if there's any other questions coming through for the speakers today, if you guys want to go ahead and post them into the Q&A now. Otherwise, I'd like to let you guys maybe give us a couple of closing statements. And again, I'd like to thank you both for your time. And I'm sure I'm going to have many questions, and we'll have many email conversations, you and I, in the future. And thanks again to American Society of Regional Anesthesia and for PAJUNK for putting this together for us. Thank you, everybody.
Well, thank you, Dr. Gamble. Just as a closing remark, I just can encourage everyone to do the transition, to plan it properly. As Dr. Hillermann already said, there is no difference in the feel from Luer material to NRFit material. Of course, in the beginning, you have the usual problems with any transition, but I guess if now I had to switch back to Luer packs, I would look like, what is it? It's different now, and I'm also already used to NRFit. And this is a little process which you have to go through, but if you plan properly, I think you do a lot for your patient safety.
Yeah, I couldn't agree more. I think it's, you've just got to go and do it. It's I couldn't now think of anything anything that would make me go back to to Luer. It just feels right now that, you know, the syringes are yellow, everything's different, and you just get I think it's doing the patient safety aspect a great service to change.
The yellow color is great too, because it's just one additional layer of, you know, like the yellow syringe goes to the yellow hub. You know, it's just an additional safety barrier. Well, thank you guys very, very much. And thank you everyone today who joined us on the webinar. For any other information, please visit www.pajunk.com. And if you'd like to watch this recording, it is available on their YouTube channel. That link was posted a little earlier in the chat. So you can rewatch and get any of these information or any of the emails and contacts that were released in the webinar here today. So with that said, I'd like to just thank everybody and close this out. And I hope you guys have a good rest of your evening. I know it's late there, and we'll be in touch again soon. Heidi and Paulina, thank you very much for putting this together for us.
Thank you.
Thank you.
Thank you, everyone.